This video demonstrates the technique of surgery for esophageal atresia with distal tracheoesophageal fistula while preserving the azygos vein in a 3-day-old male neonate without any other associated congenital anomalies. 1:400,000 lignocaine with adrenaline was infiltrated in the line of the curved incision below the tip of the right scapula. The patient was placed in the lateral position with the right side uppermost and the arm gently abducted above the head. The skin was divided in the line of incision and the deeper tissues with electrocautery. The subcutaneous tissue, the latissimus dorsi and the serratus anterior muscles have been divided in the line of incision. Here we can see the two muscles being divided, the serratus anterior towards the anterior side and the latissimus dorsi posteriorly. The division is continued until the ribs are visible together with the intercostal muscles. Using a small Langenbeck retractor, the inferior angle of the scapula is lifted and the ribs are counted downwards to establish the third intercostal space. The intercostal muscles are then divided with diathermy at the superior border of the fourth rib in their full thickness to gain access to the thorax. The few remaining fibers of the intercostal muscle are spread apart using a curved hemostat. Separation of the intercostal muscle exposes the underlying parietal pleura, which can be seen in the depth of the wound, and a wet piece of gauze is then used to separate the parietal pleura from the underside of the intercostal muscles and the ribs above and below the incision. Progressively, the intercostal muscle is divided towards the posterior side as more and more of the pleura is separated. Once an adequate space has been created inside the chest, the ribs are gently spread and a phenociator retractor inserted into position. The blades of the phenociator retractor are gently spread to allow continuation of the pleural separation posteriorly towards the vertebral column. A medium-sized malleable retractor is used to retract the lung anteriorly while pleural separation is continued over the posterior mediastinum until the curve of the azygos vein is clearly visualized. The phenociator retractor is spread further to increase the exposure. And the pleural separation continued above and below the arch of the azygos vein. Usually the first two tributaries of the Azygos vein arise from ribs which have been spread in the incision. In the depth of the wound immediately below the arch of the azygos, it is now possible to see the lower esophageal pouch with its white vagus nerve coursing on its anterior surface. Using a right-angled Roumel forceps, the lower esophageal pouch is mobilized in the posterior mediastinum both anteriorly and posteriorly before being elevated and looped with an infant feeding tube or rubber sling. Subsequent to this, the azygos vein is lifted off the lower pouch and an adequate space created beneath the arch of the azygos vein. In order to protect the azygos vein from harm during the subsequent dissection, the isolation of the lower esophageal pouch in its sling is carried above the arch of azygos by pulling the two ends of the sling under the azygos vein so that it is now situated below the point of dissection. Needless to say, this maneuver needs to be done gently so that the azygos vein itself is not damaged. It is a fairly strong structure and will withstand looping of the sling underneath it without any problems. The dissection of the lower esophageal pouch is then continued as high as possible till the junction with the trachea or the right main bronchus is clearly visualized. With the knowledge that the lower esophageal pouch has a segmental rather than a longitudinal blood supply, minimal mobilization above the arch of azygos is done to clearly delineate the junction of the lower esophageal pouch with the airway. The vagus nerve needs to be carefully protected during this dissection, and if necessary, the esophageal sling can be resighted. Once the junction of the esophagus and trachea is clearly delineated, it is time to ligate and divide the fistula. In order to be sure that the esophageal anastomosis can be accomplished comfortably and the distance between the pouches will not lead to undue tension, a size 3.5 endotracheal tube is inserted into the upper pouch and moved by the anesthesiologist. As you can see in this patient, fortunately the pouches lie very close together. The blunt end of the upper pouch is clearly visualized, lying adjacent to the junction of the lower pouch with the trachea. Once the feasibility of the anastomosis has been decided, it is then time to ligate and divide the tracheoesophageal fistula. It is my practice to use a single circumferential suture of 4-O proline which transfixes the fistula at two sites, anterior and posterior, as shown here, to control the fistula. In my personal practice of more than 100 patients of esophageal atresia, I have not had a single recurrence of the tracheoesophageal fistula using this technique, and only a single stitch is involved and a single knot is to be knotted. What is important in this technique, however, is that the suture should be anchored at 2 points in the wall of the fistula so that the knot does not slip from its position, leading to reopening of the fistula. Usually it is possible to do this comfortably with a single suture. After the fistula has been ligated, stay suture is also taken a little more proximally than the tracheoesophageal junction, and this is to prevent the retraction of the lower pouch below the lung. Once the stay suture has been secured, the fistula is now divided, carefully guarding the underlying trachea and the azygos vein. After division of the fistula, the same feeding tube is passed into the distal pouch until it enters the stomach, and this helps to evacuate the entrapped gas in the stomach and also demarcate the lumen and two walls of the lower esophageal pouch. The upper esophageal pouch is now tented again on the endotracheal tube in its lumen and the end dissected to provide a clear anastomosis with the lower pouch. As the two ends are lying fairly close together, they come together easily without tension. The lumen of the upper pouch is opened in two layers, first dividing the muscular layer and then a small divot of the mucosa. It is helpful to take a stay suture in the upper pouch also, as after the lumen is opened, the stretched upper pouch tends to retract upwards. For dividing the lower end of the upper pouch, the muscular port is held in toothed forceps and a disc is cut out of the muscle layer of the lowermost end of the pouch. Majority of times, the mucosa does not get divided during this maneuver and has to be separately caught and carefully divided to provide the opening in the upper pouch for the anastomosis. Needless to say, one should take care that the size of this opening is as close to the size of the lower pouch as possible. Once the opening in the upper pouch has been created, the posterior most suture is inserted, taking the needle from inside the lumen to the outside. This is the most crucial stitch of the anastomosis and should be applied without rotating either pouch. After the upper pouch, the suture is passed through the posterior wall of the lower pouch and brought out inside the lumen, and the knot is then tied with inside the lumen of the esophagus. By the tying of this suture, the two pouches are brought into approximation and subsequent insertion of anastomotic sutures is made easy. We can see here that the openings of the upper and lower pouch are almost the same size, and this helps to prevent subsequent anastomotic narrowing. The first anastomotic suture is secured in a hemostat, and subsequent sutures are applied from outside inwards, taking the walls of both the upper and lower pouch if convenient, and individually as the case may be. Usually 4 to 6 sutures are applied starting from the posterior wall. The knots of all these sutures lie on the outside. Once the posteriormost suture serves as a guide, there is no further advantage to be gained by holding all the stitches in artery forceps, and it is quite helpful for convenient surgery if unnecessary stay sutures are also removed at this time. If there is no tension on the pouches, the esophagus will not retract, and the suture holding the ligated fistula, the stay sutures in the upper and lower pouch, are therefore removed, leaving only the posterior anastomotic suture as a guide. This is important to prevent the surgeon tangling themselves in a maze of stay sutures in a small incision. Here we can see the posteriormost suture of the right hand side being applied, again from outside inwards, so as to situate the knot on the outside wall of the esophagus. The azygos vein lies very close to the anastomosis, but is conveniently retracted downwards by the thumb forceps. We can therefore see that not even a single tributary of the azygos is divided during this operation, and the vein is maintained intact. It is our belief that this helps in the prevention of post-operative edema at the anastomotic site, and therefore reduces the chances of leakage of the esophageal anastomosis. Once the 3 posterior wall sutures have been applied, the feeding tube is removed from the lumen of the lower pouch, and a nasogastric tube, usually size 6, is advanced down the esophagus to traverse the anastomosis and into the stomach. This serves to demarcate the lumens of the upper and lower pouch, and will also serve as a means of tube feeding from 24 to 48 hours after surgery. Suturing is now continued around the circumference of the esophagus from the posterior to the anterior side, and because the pouches are so close together, they come together easily without tension, leading to a robust and a well vascularized anastomosis. This is the single most important factor in the prevention of anastomotic leakage. The only cause for concern is the close proximity of the ligated fistula, which is lying almost adjacent to the anastomosis in this patient. However, we have not seen any incidence of recurrent tracheoesophageal fistula using a single suture ligation. As necessary, any one of the sutures can be held as a guide so that additional stitches can be placed adjacent to them for further security of the anastomosis. The anterior wall sutures are usually the most convenient to apply, and again the azygos vein is retracted downwards to prevent damage from the needle. We are now nearly at the end of the anastomosis with just a couple of sutures remaining to be inserted, and we can see that the two ends of the esophagus lie comfortably together, and in fact the upper and lower pouches seem to be of the same diameter. In this regard, this particular baby is lucky, as we have all seen that sometimes the lower pouch can be very thin walled and flimsy. So it is fortunate indeed to have a lower pouch with good quality musculature. As before, the unnecessary stay sutures are divided and the anastomosis is complete. The intact azygos vein can be seen lying in its own position relative to the anastomosis. After finishing the anastomosis, it is my practice to insert an intercostal block of 0.5% bupivacaine into three intercostal spaces from inside the chest, because the intercostal spaces are most clearly visualized. 0.25% bupivacaine is also infiltrated into the layers of the wound to provide good local analgesia in the immediate postoperative period. We know that the immediate postoperative period is the most critical for these babies, as respiratory compromise can occur due to the pain of the thoracotomy, and providing good local analgesia helps to tide over this period in babies who are not electively ventilated. We are not using an intercostal drain in this patient, as the anastomosis seems fairly secure and there is a very low chance of leakage. The ribs are approximated by two sutures of 4,0-polygalactin placed at a suitable distance apart. We know that there is usually no distraction force on the ribs in a thoracotomy incision, so no more security is necessary. We have not had problems with this method of chest wall closure in over 200 patients of esophageal atresia performed in my department. Once the ribs have been approximated, it is now time to begin closure of the thoracic wall muscles, starting from the anterior serratus muscle and continuing posteriorly into the latissimus dorsi. There are many different ways of doing this. It is our practice to use a 4-0 polygalactin suture in a continuous over and over stitch going from the anterior to the posterior side of the incision. And again, this has worked very reliably in our hands. A few additional interrupted sutures being applied to the second layer of muscle for added security, and this completes the closure of the thoracic wall muscles. Skin closure techniques vary greatly from institution to institution. At the time of this operation, I have used a 4-0 proline suture in a running over and over stitch to close the skin. However, interrupted or continuous subcuticular stitches are now the norm for skin closure in these patients. Post-operatively, we usually begin feeding through the transanastomotic tube 48 hours after the operation. Our patients are not electively ventilated. Only those babies are referred to the ICU for ventilation who show inability to maintain saturations in hood oxygen or have a very bad chest before the operation. Overall, about 5% of the patients require post-operative ventilation in our department. A contrast X-ray is done at 7 days and the patient discharged if there are no problems. Thank you.